In women who are living with endometriosis, if they're moving into this stage of life and they're already experiencing this suboptimal progesterone, maybe simultaneously with estrogen excess symptoms, can they expect that this transition might be a little bit more uncomfortable than for the average woman?
Yeah, I mean, I'm sorry to say probably,
Yeah.
because there is so much overlap there. And if you've already got, a hole in your boat, so to speak, and now we're drilling it bigger, then yeah, you might feel it sooner and or harder than the next gal. However, I would, always trying to find this silver lining and flip the script a little, not to diminish the hard. But the good thing about a woman with endo who's coming in with that situation is she likely is so far ahead of the average woman in her understanding of hormonal rhythms in her body, of, the process of endo, the importance of progesterone, what are the options, difference between synthetic progestins versus bioidentical. All of those conversations the average woman has never thought of or had to look in for herself. And so
Dena Norton has been a registered dietitian for over 20 years, working in both the conventional medical system and in the holistic and functional medicine spheres. After helping midlife women with their health and hormones for years, Dena entered her 40s and was hit with nagging symptoms like low libido, love handles, and sleep disturbances herself. This wake-up call drove Dena to research perimenopause more deeply than ever. And after applying what she learned, has reduced her symptoms and feels back in control of her health. And now Dena is passionate about helping fellow 40-something women navigate this topsy-turvy stage of life through her 40s Fix program, which leverages proven strategies to curb nagging symptoms and to significantly reduce the risk of the chronic diseases that plague so many aging women. In today's video, I had the pleasure of interviewing Dena on the overlap between perimenopause and endometriosis. Dena defines perimenopause for us. She breaks down the symptoms of perimenopause to be on the lookout for. We talk about commonly prescribed medications and how they might affect both endo and perimenopause. We also discuss how your hormones shift in perimenopause and how women with endo might experience this differently. And lastly, Dena gave us some actionable diet, lifestyle, and supplement tips to help you navigate the stage of life with endometriosis. Happy watching. I am joined today by my favorite go-to resource for perimenopause, perimenopause information, Dena Norton, who's a fellow dietitian, fellow colleague. So Dena, to start us off, could you give us a brief intro of who you are and what makes you a great person to talk to on the topic of perimenopause and endometriosis?
yeah, well, I'm a dietitian by background. So I started my career actually in cancer, and then came home to have a family. So I had a few years intermission there doing all that. And then I sort of inched my way back into nutrition. It's definitely a passion of mine, and basically went through a health, crisis of sorts of my own, hormone dysfunction and IBS, and just kind of the whole slew of weird symptoms that nobody had answers for. And that's was really my first foray in going outside the box, so to speak. So I was always like interested in natural things, but still, as long as they were within the four walls of like published research and conventional medicine. But really that experience pushed me more into the like holistic functional medicine types of spaces. And that's what really helped me heal from the inside out. So that experience of healing from inside, made me passionate about helping other women do the same. And so I, over time, accidentally backed into a private practice where I was helping women do that. And then spent really 6-8 years doing a lot of hormone support and digestive dysfunction and all of that. Love it, learned a lot. And oops, woke up in perimenopause one day. And, looking back was like, I think this has kind of been brewing for a few years and I should have known. Like, I test hormones, I know about the body. And even it took me a while to kind of wake up to the reality of it. So that was several years ago now. And as I tend to do, I know you're kind of this type city. When I wake up to a reality, I'm like, time out. Let me go learn everything I can learn anew about this. Because now I got skin in the game and like it matters that I not just know some brief things to tell people, but like I want to make sure I'm doing everything I can for this to go well for me. So that's kind of my current passion project these last few years is I came through it. I saw a lot of benefit from changing strategies and learning about new things that are important in this stage of life. And I know that so many women out there, perimenopause and menopause affect 100% of women. We all come about it in different ways at different times and have different experiences with it. But it's coming for us. So I know a lot of women feel, they felt when I started this at a loss. No one was really talking about it. Menopause, much less perimenopause. And we've almost like swung the other way, at least in some circles, where there's so much information now that it's constant overwhelm for the average woman out there who's like, I definitely don't feel good. Things are definitely changing, but I don't know where to start or what to believe or what to do. So whether it's the people who are just lacking information and help from their providers, or whether it's the women who are like, it's filling my feed, but I don't know where to start. It's super exciting for me to be able to like partner with them and help them distill the noise and focus on the main things, because you really can do so much in this stage of life to feel great and be healthier and get on the trajectory you want to be on for the second half of your life.
Yeah. I love hearing that. And what I've learned about perimenopause, mostly from you actually, and resources that you've suggested, it really can be a scary, confusing stage of life. And so one, it doesn't help to be overwhelmed with information, and two, it's so comforting to hear there's so much that we can do to improve those symptoms and live a good quality of life, and to tack endometriosis onto that. And that's really the theme of our conversation today, kind of perimenopause in the lens of endometriosis and how it might look a little bit different. Could you just maybe describe what is perimenopause? We can just kind of get that definition and what it is that we're talking about out there.
Yeah, so I think starting with definitions is really helpful. And to define perimenopause, you have to first define menopause. So menopause, by definition, is the 1 year anniversary of your last menstrual period. So assuming you're having menstrual periods, you don't have your uterus removed where you don't bleed, or you're not on birth control where that's being suppressed, but the date when 12 months ago was your last period, now you're officially menopausal. Happy birthday. You can call it postmenopausal if you want. It's all the same thing. So that's menopause. So perimenopause by definition literally means the time around menopause. So like a lot of medical definitions was basically just like, she's getting close, folks. And it really wasn't given a lot of attention in research or really even in medical care for many, many years. It was just like, yes, it's getting bad. And like menopause is probably coming soon. There has been a lot more research in recent years on it and a lot more focus on it, which I think is super important because we want to be proactive about this and stay ahead of the ball in some really important ways for our current situation, but also for future health. So perimenopause is I would say on average, it's 4 years. I think, depending on the study you look at, but 4 years or so of things related to hormonal shifts, mostly in the downward direction, that are leading you into menopause. For some women, it could be more protracted, maybe 8-10 years. Some people say even a couple years longer than that. So for a few years or a decade prior to menopause, you might start experiencing some whispers, some shouts. It's different for every woman. You might have symptoms in various parts of the body. You might have, if you're some of the one of the 25% who don't have symptoms, you might have not much going on the radar. Maybe you skip a period or so. Maybe you stop having periods down the line, but you don't have other symptoms to speak of. But there are changes going on under the surface for all of us as we lose these hormones, because as your crowd knows, hormones are powerful and they affect all areas of the body. So whether it's in symptoms or whether it's in blood work and physiological changes under the surface that are directing our health, we are beginning this process of adapting to the loss of hormones and suffering in some ways the loss of hormones over a short course or over a longer course. And then post-menopause, obviously, there are no hormones after that, excepting replacing them. And so the body lives without them after that. So that's kind of it by definition. It's the bridge to menopause. Menopause is basically your ovaries retiring. So that's it by definition, but of course, a lot of aspects of health, endometriosis being one of those possibles, as well as medication, surgical interventions, etc., can disrupt that timeline and that experience.
Yeah, love it. Thank you for that definition. One thing that you used to say, I can't remember if it was in like one-to-one conversations with me or through your content on Instagram, but you always used to say that loss of your period isn't a common like first symptom that a lot of women going into perimenopause experience. You've alluded to a few of those symptoms. What are some of those symptoms? And do those symptoms always correspond with what we're seeing reflected in lab work or what we might expect the hormones to be doing in these various stages of perimenopause?
Okay, great question. Yeah, so I will say, based on the medical literature, there are two stages of perimenopause, early and late, basically. I generally will side with one big study that divides it into three stages because so many women at earlier ages now are more aware and starting early, like I did, and probably will have a more protracted course over 6 or 8 or 10 years. And so it's really helpful to divide these sort of like symptom buckets and hormonal changes across a longer time frame. Okay, so you have early and late, or we'll just say earlier and later, knowing there's some mush in the middle that may not be super well defined. But I would say the symptoms that are more common earlier go with the hormones that are declining. So, in the endo world, I'm sure your audience is very familiar with the major effects of some of these hormones. So physiologically, it's pretty normal for women to start seeing a little bit of a decline in progesterone, maybe mid-30s, maybe late 30s, depending on the situation, right? Maybe if there's excessive stress in the environment, other hormone disruption, other things, maybe that's accelerated or earlier, but progesterone starting to decline is one of the first things that we see symptoms of, alongside testosterone for most, but not all women, starting to decline as well, somewhere around that same time frame. So symptoms like, I'm more anxious, I can't get to sleep. Those are super, super common earlier on. I would say oftentimes you also have maybe more fatigue, maybe some brain fog, libido goes through the floor, maybe you start to get a little bit of a love handle midsection situation that wasn't there before or wasn't so bad before you could manage it and it feels out of control now. Those would be some of the most common, categories of symptoms I see in the earlier stage crowd. And then when you move deeper into perimenopause, well, I should say another common area is period related changes. As you said, it's not always a part of it, but it is for some. And most common earlier shifts, again, are probably pretty expected if you understand what low progesterone or estrogen dominance, which not everybody likes that term. I understand why, but the situation where you have relative to estrogen, not enough progesterone. So you can have more PMS, more mood swings during that time, maybe headaches leading into your period. Maybe the periods themselves are heavier or more clotty. So that kind of, typical estrogen dominant sort of scenario or appearance is pretty common in the earlier stages of perimenopause. And then if we slide into it more, kind of the middle area is where most women are going to be like, okay, I thought I was seeing something and now I know it. This is not, something is not right. It may not be 1 or 2 areas. Now it might be 3 or 4 or 5 or 6 areas, or the symptoms are really intense. But that sort of middle section is where you might start to see, oops, I skipped a period. That's odd. That's not like me. You might start to see some hot flashes or night sweats, or what's never talked about, but I experienced this and it took me a while to realize what it was. It's more like a warmth. It's not hot. I'm not ripping clothes off. I'm not sweating, but these kind of whispers of something that's, a temperature regulation issue. Certainly the mood swings, the anxiety, as well as low mood, can become more prominent sort of midst of perimenopause. Digestive issues are pretty common because we have hormone receptors the gut is rich in hormone receptors throughout, so we can have a variety of digestive symptoms. Definitely brain fog, maybe some forgetfulness. This time, why did I come in the room? I can't think of a name on the spot that I should know. This sort of word finding type of thing, that all can start to peak. This is the time where women are like, this is not me. It's not just I gained X number of pounds, I'm not sleeping so well. We write that off as all kinds of things because those are multifactorial symptoms. But this is the season deep in it where women are like, time out. I don't care what the doctor says. I don't care what Google tells me or doesn't tell me. This is not me. And that's when they get loud about getting help and finding answers. So that's kind of the middle section of perimenopause where you are for sure in it. You know it, even if you don't know what words to put on it. And most savvy doctors will be like, sorry, sis, this is perimenopause. They don't often have a lot of solutions for it, but they do validate that this is probably what this is. And then the deeper and deeper and deeper you go toward that menopausal date, obviously the more classic symptoms, for sure, hot flashes and night sweats, for sure, you're not having periods very often at all. Obviously you have a period that it's 12 months until your next one. That's a whole 12 months without them. So it's almost okay, you're pretty menopausal in those final stages, which are months or maybe a couple of years. So that's kind of the trajectory of symptoms. a lot of women, the nearer and nearer they go to menopause, the symptoms get louder and louder for obvious reasons. You get less and less hormone to tamp these symptoms down. But there are some women for whom some of the symptoms, like some of the mood changes, some of the sleep changes, and other things will start to sort of quiet down because yes, there's less hormone, but there's not as much volatility and flux of hormones. And part of what's driving the symptoms is not just the loss of hormones, but it's the way that we lose them. It's all this volatility, and it's the brain screaming because it doesn't see hormones. And the brains and the ovaries are kind of in this, like, the brain and the ovaries are kind of in this years long sort of like shouting match. Like, I said do this. No, I can't. Yes. Okay, fine. That's kind of what it's like. So as that sort of quiets down and the brain's like, all right, girl's retiring. Let's just give her a send-off party. I accept. Some things will quiet down for some women. And then post-menopause, according to the research, for some women, it's, 2 or several years of fits and spurts of symptoms, even after the ovaries are pretty much offline. Now, all that assumes, again, you're not taking birth control, you're not using hormone replacement therapy, you're not somehow topping off the tanks of these hormones that would, in a way soften the blow of the symptoms or quiet the symptom patterns. And all of that says really nothing of sort of the quiet or sometimes silent under the surface changes that are happening as a result of those same hormonal shifts. The loss of the hormones, obviously, but also hormones, because of all the wonderful things that they do, as we lose them, we lose some of our ability to manage inflammation. We lose some of our ability to regulate the immune system. We start to lose bone mass. We definitely start to lose muscle mass. We start to lose brain volume and function. It's, every area of the body really is affected. Our lipids start to go up. Our blood sugar and insulin tend to go up. This isn't for everyone. All of this is going to happen, but for everyone, probably some of this is going to happen. And, those things I just mentioned, the sort of under the surfaces, these are the things that aren't often talked about because, of course, we're all like frustrated with symptoms and wanting to relieve them. And yes, you deserve that. But these are the things that direct your health. These are the things that take a decade or more to develop into disease and diagnosis. And these are the things that kill women. So cardiovascular disease, stroke, dementia, diabetes, cancers, all of these things are really like the recipe is really cooking in perimenopause, and it's going to take years to bake the cake. But now's the time to like get ahead of the ball, stay there, pop the hood, know what's going on quietly under the surface. Even if you don't feel so bad, don't be the woman who's like, I can manage. It's not so bad. Like, don't be the hero. That's great. I'm happy for you. But also, it's time to cast a broad net and look under the hood and make sure that you're like sitting pretty for this experience so that you're captain of the ship, So that's kind of a long and winding road to answer your question.
No, it was a great answer. And I have so many follow-up questions, but I'll start with this one. So we had been talking before popping onto the recording about progesterone resistance and estrogen dominance. And for a lot of women with endometriosis, even in their fertile years, in their late teens, early 20s, early 30s, they're living with low progesterone or progesterone resistance, which we know is part of the pathophysiology of endometriosis, right? So you have enough of these. I would very simply define this or describe this as you have enough of these progesterone receptors, but they're just not very receptive. So you're not getting that progesterone binding. There's lots of implications of that for the way that you live with endometriosis. But for the purposes of this conversation, your progesterone levels are just not going to be as high as they should be. And a lot of women with endometriosis are likely already experiencing a lot of the symptoms you just described, the anxiety, the issues falling or staying asleep. I find it often presents with spotting leading into the period or tail and brown bleeding, which could be more estrogen related, but a lot of those types of symptoms, heightened anxiety. So my question, Dena, is, in women who are living with endometriosis, if they're moving into this stage of life and they're already experiencing this suboptimal progesterone, maybe simultaneously with estrogen excess symptoms, can they expect that this transition might be a little bit more uncomfortable than for the average woman?
Yeah, I mean, I'm sorry to say probably.
Yeah.
Because there is so much overlap there. And if you've already got, a hole in your boat, so to speak, and now we're drilling it bigger, then yeah, you might feel it sooner and or harder than the next gal. However, I'm always trying to find this silver lining and flip the script a little, not to diminish the hard. But the good thing about a woman with endo who's coming in with that situation is she likely is so far ahead of the average woman in her understanding of hormonal rhythms in her body, of, the process of endo, the importance of progesterone, what are the options, difference between synthetic progestins versus bioidentical. All of those conversations the average woman has never thought of or had to look in for herself. And so she's got to make up all that ground, not to mention figure out her symptoms and how to just feel okay on a day-to-day basis. But yeah, I think to answer your question, it's very likely that especially that earlier season might be rocky seas more so than women without endo. And I think a lot of it is because they're coming in with some of this going on already for other reasons. But I think it's also because even apart from endo, if we think about stage 1 and, halfway into stage 2 of perimenopause for non-endo women, we can sometimes have higher than ever estrogen peaks. They don't stay for long, but because of this gradual disconnection between the brain and the ovaries, physiologically what happens is progesterone is falling. So we've already got that gap that promotes the estrogen dominant kind of symptoms. But as estrogen starts to figure out where she is in that mix, she might go down a little and the brain's like, hey, no, you don't. And then it screams at the ovaries and the ovaries are like, okay, fine. And then it peaks it out. And so estrogen ends up doing this wild roller coaster thing. And so there are times where not only is estrogen starting to trickle or drop, depending on the woman, you've got estrogen at times like sky high. And that gap gets crazy big. And then it might go down and then it goes up again. So for everyone, there's a lot of chaos and volatility for sure in the estrogen department, alongside some degree of progesterone drop. And then you sort of just probably magnify that a bit if you already started there.
And there's a ton, I'm sure, that's within our control to improve with these hormone shifts, which we will talk about. But also, when the estrogen specifically is doing that, it's like a little bit less within your control because it's just kind of like the stage of life you're in, right? Like it's kind of expected to jump up and kind of drop a little bit in those early to mid stages of peri, right?
Yeah, I would say it's very normal. I mean, we definitely want to orient as best we can lifestyle to soften that blow. And then there are some hormone therapy providers. I would say it's the minority and they're not so conventional. They're more like on the edges in other crowds, the more natural and functional crowds. But some of them would say there is a role for in the very volatile estrogen phase, like dropping a very low dose of it, maybe at times, maybe all the time, just enough to signal the brain to stop screaming so that you take this and make it more like this. I'm not a prescriber. I'm not like knee deep in all the nuances of that. There aren't that many of those folks out there, but they are out there. So, I don't know what to say about all that, except for that I know with endo women, like with other kind of niche health diagnoses that lack research and lack care, just putting that seed out there to like, you might have to think outside the box and consult with prescribers and providers who think outside the box, not because they have the answer or everybody conventional is wrong, not that, but because if you feel like you've done a lot of the recommended things, there might be other ways to just like experiment with something briefly in a, gentle way to see if it offsets it for you.
Love it. Love it. Okay. What are your thoughts? This is kind of similar to one of the questions I had sent to you in preparation for the interview. What are your thoughts? Let me phrase it this way on OBs, gynecologists, doctors working with endometriosis patients who say, just take this pill or this hormonal suppressant until menopause. I'm confused. What happens? Do you transition through this whole life stage until you're no longer having cycles? Are you symptomatic while you're on this pill? Like, what can we expect? I know that this is a little bit of a what's the term? Anyway, it wasn't a question that I had prepared for you. Are you prepared to answer this question?
Sure. Yeah. Let's talk about it.
Thoughts, Dena?
Yeah. With, the obvious disclaimer, Cindy and our dietitian's not medical friends.
Sure. But, of course.
Of course. I think it's honestly, I think for the woman with endo, it's probably not that different than for the woman without endo, that for whatever reason is put on birth control to get her through this crazy thing. I'm not feeling it so bad. And then we'll figure out what to do with you later. And I will say the like party line conventionally, based on what I've seen in medical guidelines and I've seen conventional providers do, is, and you'll even see this, I even saw it in a paper that was published, I think, in 2023, if I'm not mistaken, but it was a review paper on endometriosis and HRT. And like, what do we do with these ladies? Can we give it to them or not? Like, that's what we all want to know. Anyway, but some of the summary statements from those authors were, granting that we just don't have research to say it's off the table. It should obviously be approached with caution and individual considerations, et cetera, et cetera. But it may be the benefits outweigh the risks, certainly for women who, because of surgical or medical induced perimenopause or menopause, especially early on, and the accumulated health risks of going without hormones for very long, the benefits probably outweigh the risk, and we could at least put them on, a synthetic hormone combination until the age of natural menopause. So that phrase has been used in non-endo populations to figure out what to do with these women who need symptom control. We just slap them on birth control or whatever we do to like quiet the symptoms and help them hang on through this. And then because there aren't really hormonal signals as to when you're menopausal or not, because the birth control would be disrupting that, then the going, approach has been, we take them off at the age of natural menopause. And the more recent conversation on the heels of that is we switch them over to bioidentical, FDA approved hormone therapy, a patch. If they have a uterus, they will give you progesterone. I mean, that's not necessarily what I would recommend, but that's kind of the discussion that's had. It just is that it's sort of like a cookie cutter, like, I don't know, give them a little something. And then when they're done with that, we'll like give them something different. It doesn't seem to be, in my opinion, very like, I don't know, thoughtful, thorough, physiologically accurate, based on the sum total of research. But you do hear that. My phone's ringing, so sorry, cancel that.
No worries.
Anyway, so that's that. I would say about like Lupron and other hormonal suppressors, I'm not so up to speed on all that, but what my understanding, and I've like grazed the surface of some of the endo literature in some of these areas, is if you have medically or surgically or spontaneously undergone, premature ovarian insufficiency, or, early menopause, so to speak. I mean, for you, it's really a different conversation because now we're thinking, how many decades are you going to live? Probably many. Like, we really have to consider those longer term health risks, the bones, the heart, the brain. How do we protect that? And the conversation takes a little bit different turn because of increased risks, by going into that situation so early. For everyone else, though, I think it really is more stepwise and nuanced, and it needs to be aligned with how you want to care for your body. So these are conversations I'm having with women that don't have endometriosis necessarily, but, are working through perimenopause. And, I kind of describe like the whole buffet of options, food, lifestyle, medicines, hormones, as a buffet. Like, it's not like there's only one path you have to take, or there's only one right version of hormones or one right version of diet. It's like there are many, many options. And the more informed you go in, having done your own research, the more you can advocate to find the right providers who not only are expert in endo, you have to find people who are expert in hormone replacement therapy. And it's probably different individuals that you're consulting with, probably not one. And then the more you can confidently advocate and share those decisions with how you're treated. Because, I mean, there are a lot of unknowns here. There's a lot of evolving research. I know in endo and in perimenopause and menopause, like, we don't know it all, but we're all living in real time and having to make these decisions. So I think it's super important that you learn what you can, learn about your options, and really vet out providers who aren't just expert in endo and aren't just expert in HRT. They're aligned with like your preferences. Because I choose some outside the box things that have less research than other things. And I choose other things that are like, they're the most solid from an evidence-based medicine research standpoint. But that's because I've sort of consulted with people and research that I'm comfortable with, and I've assessed the risks and benefits, and this is how I want to do it. And I'm the only one who gets to enjoy those benefits and has to live with those consequences. So it's my decision. As I consult with research and providers, it's not like I can only do what they say or can only take advice from the people who are in charge. So that's a little bit of a rabbit trail rant, but I know you feel the same, Cindy, and like empowering women to advocate, learn, advocate, and seek people who know what they're doing, and who want to partner with you to get what you want.
100%. 100%. I love that. It was really interesting that you mentioned about the primary ovarian insufficiency. And if you're quite young, or maybe, quite a bit younger than the average woman who might be moving through peri into menopause, then you've got a longer stretch of, this longer window where your risk for all those things that you mentioned previously, could be affecting your health. And so that is very relevant, I think, for people in the endometriosis space to hear, right? Be proactive, seek out these specialists, start reading about HRT, what you might consider, exactly because, your heart disease risk goes up, your cancer risk goes up, all of those things that we don't want to be dealing with, in addition to living with endometriosis for the last 30 years of your life at that point.
Yeah. And I think, Cindy, you can sort of check me on this. My understanding is that, probably with endo, similar to with perimenopause, there are kind of like two buckets of consideration, right? There's the symptoms. How does it feel? Can I live my life? Am I well? And then there's the what's actually happening in the body? Does that carry health risks that are, unrelated or invisible with regard to my symptoms? And we really want to tend to both. And it's definitely a juggling act in a lot of ways. But I think correct me if I'm wrong, definitely in perimenopause, when the conversation is about suppression and symptom management, when that leads the conversation, those are valid things. And sometimes they're necessary. I feel like they're sledgehammers in some ways, right? Like, if you need them, thank God they're there. If you don't, let's at least set them to the side and consider, can we find a hammer? Can we find something that will do the job in a maybe gentler but effective way without so much collateral damage or unintended consequences? So when we're talking about symptom management and when we're talking about conventional medicine's approach to symptom management and suppression, oftentimes it's synthetic hormones. It's just like blanket recommendations. It's not really trying to get in and understand your cycles, your patterns. What have you observed? What's in your app? What do you notice at this time of the month? What foods set you off? What lifestyle things set you off? How has your experience been with this medication or that one? What is your pain level? Are you able to live your life? All of that should really go into the conversation of how heavy an approach do we need? And are you of the mind to try something for a month or 2 or 3 and see what we get out of it? And we could always go heavier later, because we could explore really high dose progesterone. We could explore a super aggressive anti-inflammatory diet. Are you willing to spend a few $100s on supplements over a few months? We could try it and see, do you respond to it? And then make your decision about, is that a path you continue to follow? Or is it time to be I tried everything. It's just time to give in and take the meds, which is a whole nother conversation, the morality we attach to all these things, right? Which I think is unfortunate and doing us a disservice as well. It's really just a spectrum of options, and you just need to make an informed and empowered decision at each chance, at each opportunity with the team that you have. It's not like you have to sell yourself out and take this med or only be natural or any of that. It's just, what order do you want to go in? What makes sense to get you the most and introduce the least amount of other, risk.
Yeah, I totally agree with you. And I think that is that's a question that a lot of women in the endometriosis space ask themselves when they're presented inevitably with that option, when they go to their doctor and they're like, these are my symptoms. And they know that well, you should go on the pill or Alyssa or Luca. Yeah. They know that conversation is coming.
Right.
And I'm so neutral when it comes to hormone therapies and birth control, when it comes to improving your quality of life with endo, because I think they can absolutely be helpful. I just want women who are considering taking these medications to be informed about what they could be doing in your body, which is partially what
I've had a few clients, most clients are not this way, but I have had a few clients who are I just need to live my life. In the easiest way. If it'll do the job, I'm really not concerned about it being bioidentical or not, they just want the simplest route to feeling better, and they'll deal with other things later. That's them. And if that's what they want to do, then great. Here are your options. Here are your people. And then there are other women who are I want to know all the pros and cons. So I'm going in eyes wide open. This is more me, because I spent the first few years of my career in cancer sitting across the desk from women, mostly women, some men, who said to me, I have a regret about whatever, fill in the blank. And I learned early from other people that regret is the worst thing. Regret is what you want to avoid at all costs. Nobody can control all the outcomes. Nobody can know everything and bat 1,000 when they're making these difficult, nuanced decisions. But for me anyway, what makes me make a decision with peace of mind that I can look back on and feel good about is I did the best I could with what I had. And that's really the degree to which you can control these things. But at least 5 years and 50 years down the line, you're looking back and saying, I did the best with what I had, versus I should have listened when they said that. I should have looked into that. I shoulda. And that lives over your head because you'll never know how things could have been different.
I totally agree. I totally agree. I'm not even going to add anything there because I'm totally aligned with you for sure. But speaking of medications, and I don't know if this is the best segue, I think it's probably similar for women, moving through perimenopause into menopause. We're met with all these scripts for various medications, whether that's birth control, like we've discussed, the hormone therapies, antidepressants, anti-inflammatory, pain relieving medications. So my question is, and this is a really big question, so I'll add the caveat here where we're not going to go like super, super deep dive into this. And again, with the caveat that we are dietitians, right? But how can these medications affect someone's experience of perimenopause if they're simultaneously living with endometriosis? Because we know that these medications can have some effects on your physiology, on your liver health.
Right. So I think in one way they could help with some symptoms, if you're taking medications that really level you out from a mood perspective, that may be helpful from a symptom management perspective. If you're getting it from Peri and Endo from both sides, like, it could really calm things down and maybe quickly. On the flip side, a lot of these medications have the potential to do the opposite, or they affect your mood negatively in this way, even though they help with this thing. So I think globally we could say they might help with some of the symptoms because there's quite a bit of symptom overlap here between the two. The bigger question for me is two things. One is, hey, I get you want some symptom control, but is your only goal or your ultimate goal to suppress symptoms? Listen, I've never had pain from endometriosis, so God bless you. I mean, if you need bigger guns than what natural stuff can do, then you should go get them, but do it with the mindset of the least effective dose possible so that you, yes, get relief, but hopefully can still be in touch with your body in different ways, because symptoms are guideposts for a lot of things, like perimenopausal symptoms are, helping you at least at some subjective level track, okay, am I moving down the line at this pace? What's it like? Maybe a symptom prompts me to take better care of myself in this area or do my research on that thing I've been thinking about. So they can be a blessing in a way, as well as helping you sort of track the progression. So I'm not a big fan of taking an approach where we're just like, silence them all at any cost. I know that's not what you're saying, but we do want to kind of view the bookends of extremes so that we can figure out where we personally fall, in the in-between, which is where most people live. So I do think they could help, but I do think they could also suppress too much where you don't even know what's going on, and then the other thing, which you alluded to, which is sort of the unintended consequences, if these things are suppressing stomach acid, let's say, or if they're slowing down the digestive tract, or they're increasing risk for liver and gallbladder issues and gallstones. And, that's a difficult conversation with hormones and hormone replacement that's almost never talked about in the perimenopausal and menopausal space. But they do often have unintended consequences, like SSRIs. They can be very effective to kind of numb the volatility of the emotions. Or I had a client just last week who was like, I love my life on this thing. I've been resisting it for years and I finally feel like I'm level. I'm not flat, but I'm also not crying at the drop of the hat and feeling out of control and out of body. So for her, I mean, how wonderful. We also want to know that it's probably suppressing libido, because that was already an issue in perimenopause. So what can we do to offset that? Maca has been shown to improve that when you're taking an SSRI and you have low libido. So you always want to be thinking about unintended consequences. You can Google that and get a lot of information pretty quickly. It doesn't mean your med is bad. It means it's strong. So let's be aware of what else it might do that you're not taking it for, and how we might be able to compensate with natural approaches, with other things to offset some of that collateral damage.
I love that answer. I thought that was a fantastic answer. And and you address the big things, we can say the same thing about so many of these other medications. Like if you are taking a lot of pain relieving medication as somebody with endometriosis, know that that's probably going to have an effect on your stomach and your liver. And what are the implications of that as you move into peri, and, maybe changes in lipids or your increased risk for something going on with your gallbladder or your liver. So yeah, I love that answer. I thought it was a really well-rounded, answer. And bottom line, make sure you're well informed about what you're taking, what the consequences could be, side effects. Just be informed about those, and maybe consult with somebody that you trust on how to maybe mitigate some of those, so that you can continue that smooth transition into peri.
Yeah, definitely. And I should have mentioned nutrient deficiencies. I mean, here we are, dietitians. But, a lot of these medications, birth control is widely known, but others too, PPIs and others to, really deplete nutrients in a variety of nutrients in a variety of ways. So that's something, again, to look into. And these are things that you could simply Google, nutrient deficiencies with a PPI. There you go. It's going to come up with you for, minerals, B vitamins and such. But yeah, you really want to be aware of what's going on so that you can compensate for it.
Yeah, love it. Okay. I guess my last question is around just some action items. What are your favorite diet, lifestyle? If you have some supplements, I know supplements really should be tailored to the individual, but just some general kind of advice for women who are living with endometriosis and maybe also approaching that stage of life where they're moving into perimenopause.
Yeah, well, I don't want to be anticlimactic, but I follow you pretty closely, Cindy, and you're kind of like my number one for learning about nutrition and lifestyle with endo, but it's probably going to sound like same song, second verse, which maybe that's good news, right? Like, let's flip it around and be like, you're already on it. But I would say, like, broad strokes, nutrition and lifestyle. If I had to pick a template diet, I would say the Mediterranean diet wins all day long. For perimenopause, there's definitely been data research around menopause related symptoms, which would include perimenopause related symptoms, and higher plant intake, reducing a number of those symptoms. So I think a Mediterranean base is a smart way to go. I would personally advocate for adding to that probably a little more protein than is typical in a Mediterranean diet. Being selective about what types of proteins, preferring things that are high in omega-3s and high in unsaturated fat. I mean, the same things you hear from Cindy. But I do think that balance between a Mediterranean base with an extra protein layer on top is probably the best. And I have to admit, there's not been research on this to my knowledge, but I'm sort of patching together a quilt of longevity research and chronic disease lowering research that is the Mediterranean diet easy winner, and then some sort of bits and bobs of research in older individuals, needing more protein to get the same amount of benefits out of it, in fat loss in midlife, even midlife women and aging women really being helped by adding more protein that can, even apart from any other changes you make, increase muscle and decrease body fat. And then in the sort of bodybuilding literature where they've done a better job of cranking and cranking and cranking more and seeing is there more benefit? Is there more benefit? And I do think that they make a good case for, yes, you have to feed up and combine it with the right type of fitness, but I'm a big proponent of the muscle-centric approach to aging. It's not the only thing going on, despite what we feel like on Instagram right now, where your entire job and then some is eating protein and building muscle. But I do think, most things that are that hot have a grain of truth at the bottom of them. So I do think if I had a crystal ball, we will eventually have research that basically combines those two, that says a higher protein version of a Mediterranean diet template may be even better for midlife and aging women than a Mediterranean base alone. I don't know that, but that's my guess. That's what I'm making on, because that's what I'm doing. But that's generally what I would recommend to women. So that's a good base. And then combine that with fitness. I mean, food and fitness really are the forefront. Obviously, I'm a dietitian, so those are my deeper areas of expertise compared to other things. But I also think that as we're thinking about the process of aging, which again starts now, even if we don't feel that old, the best way to minimize the risks of age to live the longest and also the healthiest life that you want to live is to build health. And the best way to build health is fitness, honestly. Like 2 degrees in nutrition, 20 years under my belt, but fitness wins this battle. So I really think you have to combine the nourishment for the body's function with the fitness, because if we can build up muscle at a time when we historically have lost it, we really do see like increased ability to lower inflammation, increased immune regulation, improved energy, better brain function, better blood pressure, better liver. It's like anything that's a problem with aging, I can't even think of an exception, gets at least some degree better with fitness. And in some cases, it gets significantly better. You know, if you can like go for a walk regularly, it reduces all-cause mortality by 40%, like no brainer. No, nutrition can do that too, by the way. If you eat like a very plant-rich diet, you know, it can have some of those same all-cause mortality numbers to fitness, but man, you leverage them both and you are cooking with gas. So those really need to be the core, in my opinion, is a whole food-based diet. Make most of your food, eat a colorful diet, get plenty of protein throughout the day in a balanced meal pattern. Don't overthink it. All those things, everything Cindy says, and then really focus on your fitness, building muscle, being cardiovascularly fit, and being a person who moves often and throughout the day. So I do think the basics hold most of the weight here. You know, everybody likes a supplement, so I'm a fan of them. Not everybody is. I would say like kind of a short stack that I think is a high ROI for, you know, perimenopausal women would be like a good quality multivitamin, some magnesium glycinate, and fish oil. Those are my tip tops. Some people would slap on vitamin D to that, which, hey, I love me some vitamin D. There's plenty of literature to show that we have less vitamin D as we age, and that increasing it improves a lot of things. But I just would take that on a person-to-person basis based on your labs. I'm not a super fan of just slapping high doses, especially fat-soluble nutrients, on everyone. So I would take that case by case. But I do think a good multi-magnesium and fish oil is good for most folks. And oftentimes, I don't know about you, Cindy, but I will run, you know, omega levels in labs just because it's a pretty accurate read and a very simple way to say, hey, is your diet enough? Or do we need to close the gap with some supplements? And these are also supplements that are quite pricey. So for people who don't need them, it's nice to say you don't need them. For people who do, it's nice to give them a specific dose and then kind of monitor, you know, are we hitting the target or not? And I kind of aim for more the Asian target than the American target based on the research. So I like more of a 7 or 8%, omega-3 level in the blood. So those would be kind of my biggies, I think. And then we'll just wrap that in a big hug that says, take care of yourself, girl. But I hope women with endo are already on that page and they're like, I know I need to honor my body and care for it by sleeping and having good relationships and finding joy in my life and purpose in my life and tending to myself as a whole person. I wish that were assumed, but for some women it's not, because we live so much of our lives, you know, dishing out and serving for others, which is very noble. But, you know, if you haven't already, it's the season to get serious about that stuff and put some boundaries and margins into your life for the sake of your health as a whole person.
And it catches up with you, especially when you're already living with a chronic inflammatory condition.
Yeah.
I don't know who she was, but this reel popped up on my Instagram a couple days back. I don't know if this was a healthcare provider. I was just scrolling, you know, as I do. Mm-hmm. And she's like, in the video, she's like, look at me, I'm like thin. And she was visibly thin, right? Her body composition. Mm-hmm. She's like, I'm thin and I have insulin resistance. And then she proceeded to say, if you don't have muscle as you age, this is your reality. Like this is waiting for you. And of course that doesn't apply to every single person, right? We all have different genetics. We do diet, all these things that we talked about do matter. But the muscle, the resistance, especially, I mean, you could be doing any type of fitness, I presume, but the resistance is big, I think, as we age.
Yeah,
right?
they're all great. And, for anyone who's just overwhelmed by like their whole to-do list and, oh my gosh, I'm always about moving the big rocks first, but I really think just like sheer movement, if you're a person who's really not moving and you're not, get a step tracker, get something objective that helps you like put a number to it and improve it, even if you don't use it forever. But, in the literature, going from pretty much nothing to 4,000 steps a day, which is not much. Like I have a very at-home life and I can get 4,000 steps in my house each day. So going from 0 to 4 has significant benefits on all-cause mortality and major chronic diseases. Going from 4 to 8 is a major step jump above that. So just move more. But it's really movement and muscle. Those are like the two anchors. Start there. So once you're like, yeah, I'm moving 8 to 10,000 steps a day, maybe even 12 if you're an A+er, awesome. It's time to like not put more into that and put some time into building the muscle with resistance. You could start with Pilates, you could start with body weight, you can start with pink girl weights, you know, whatever is safe in a start for you, but have an eye on moving well with good form, but eventually moving more and more and more weight to whatever point that you like physiologically have enough muscle on your body that you're a bit over muscled compared to your peers. And that's a good way to kind of go into the aging process to kind of muscle up a little. I mean, there's so many 50 something meatheads out there now where I'm like, that might be more than you need. I don't know. There's like a whole culture right now where I'm like, I don't know. I mean, if that's you do you, girl, but like, I'm not sure we all need that degree of muscle. But yeah, going in a little over muscled, I think is a really smart strategy. I would definitely advocate for that.
That's
yeah.
funny.
And then I think something we didn't really touch on, but another kind of, you know, big bucket area that because of what you mentioned, Cindy, you know, the blood sugar and insulin creeping, the lipids creeping, the things creeping quietly, the bones, bone density decreasing, not to mention if you've been on Lupron or undergone surgeries that remove hormones, but you don't know that. You do not know this stuff unless you test it. So, you know, I work with a lot of women who've had understandable experiences with conventional medicine in one form or fashion where they're like, they have, you know, resistance to just trusting the system and whatever. But this is not the season of life to be throwing the baby out with the bathwater. Like you really need to be like screening a broader range of labs to check on these things. And so I routinely do like a perimenopause lab screen for women. I'm like, let's get those baselines, girls. If you haven't had them already, it's time to just like get a baseline. And that is equally for, we want to find a problem early when it's the easiest to address and like nip it in the bud. But it's also so that you don't have to worry about 60% of what you see on Instagram because we're going to rule out a bunch by doing that screen. I guarantee it's not all bad. So it's really nice to be encouraged and be like, you know, like for me, like insulin, blood sugar, not my thing. Lipids. Like we've all got our things, you know? And so it's nice to know what deserves time, energy, money, and maybe a dash of worry to keep a fire under me. But what am I like? I am okay. I'm going to not worry about that. And I'm not even going to check it again for a year or two, depending on the thing. Like, I'm okay. You can really reserve your mental bandwidth, money, and effort for the things that do actually need your attention, but you don't know which those are until you really stop and check.
Yeah, I totally agree. I love testing and understanding what's going on. What do we need to focus on, right? What are these problem areas? Dena does have great content for anybody watching on labs, like Peri-specific labs. And then, of course, for the endo-specific stuff, you can certainly find those on my page as well. I'll just add one quick thing here on the diet front. I love the cruciferous veggies for my endo ladies for the estrogen elimination. And I love leaning a little bit more in towards towards the lean meats, the turkey, chicken, fish, especially just so that we're not overloading the body with the saturated fats. I love the olive oil, which is a huge part of the Mediterranean diet. Yep. The nuts and seeds, love those, love the legumes. I get a lot of people, you know, complaining that they don't tolerate them well. But even just small amounts or tacking on like a Beano enzyme or something, I love them. They're just such a beautiful food with so much fiber and nutrition.
And soy, you're a big fan of soy. I think I've come around. I've come around on soy.
Have you?
So
were you not ever around from the beginning?
I mean, I was probably a little more skittish. Again, like I started my career in cancer on the heels of the WHI study coming out saying soy or, you know, estrogen causes cancer. So it's definitely in that like spin out from like hormones. But even at that time, it was looking like the more like population-based human literature was leaning more towards soy's probably okay in whole food form in reasonable amounts. Maybe it's a different thing if you're like eating pounds of the isolate every day. So even at that point, it was like leaning toward whole food. But now I think now that I've revisited the literature on, you know, the overall value of soy for everyone's health, but even within the context of perimenopause and, you know, endo, you know, it seems to be mostly positive. So I think the special consideration I would add to soy for perimenopause and menopause is if you are someone who, for whatever reason, cannot or will not take hormone replacement therapy, then for me personally, I would double down on my efforts around soy because compared to maca and, you know, all the many other things they, you know, pitch as phytoestrogens or hormone helpers during this stage of life, my read of the literature, and I've looked at it from a symptom perspective as well as, you know, diabetes reduction, cardiovascular health, all-cause mortality, all the biggies, soy is easily far and away better than those things. Now, it's half as good as HRT on average, depending on the study. But, again, if that's not available to you, then soy is a major, I think, consideration for you on top of all the other, diet and lifestyle factors.
Dena got controversial in the space. I don't find it.
You got to follow the data, right? Like you can't, you got to leave your ego aside and change course sometimes. I mean, that's what research is, right? It is learning. That's what research is. It is not definitive dogma that gets to decide what reality is. It is the discovery of reality. So anyway, I've discovered some new bits. And shifted position.
No, I agree with you. And you're not wrong. I am a fan of soy. Yeah. Whole food sources of soy I think are fantastic. I just want to encourage people to be open, because I think
for sure.
They've heard something somewhere and they've clung to that like gospel, and they're just not even open to hearing the research.
Yeah.
And like you alluded to, if you personally don't tolerate it well, every single time you have a little edamame or some tofu, you you don't feel good, then absolutely, maybe it's not for you, but it doesn't make it bad for every single person with endometriosis or who has endometriosis and is moving through perimenopause into menopause.
Yeah.
Thank you so much for your time. It was a
it was fun
chat, very insightful. I guess I'll end it there. Thanks so much, Dena.
Thanks for having me.
Thank you so much for tuning in to today's video. If you enjoyed this video, please give it a like, share it with a friend, and hit that subscribe button if you haven't already. And I will see you in the next video.